Well, good evening. My name's Robert Patton. I'm a non-operative sports medicine, and I have the task of talking to you guys about non-surgical treatment options for orthopedic conditions. And I say task because this is a huge topic to cover in an hour, but hopefully we can come away with some some valuable knowledge here. So. Um, Let me see how I progress through this. There we go. So a little bit about my background. I was born in the U.S. In California. My father worked for the U.S. government and was stationed in England. So we moved there in 1994. I was quite young at the time. I spent most of my life in England. So I do talk a little funny, and I apologize about that. But I did all my studies in England. I went to undergraduate at the University of London. I did my medical school at the University of Warwick. Um, and I worked for a couple of years in England before I moved back to the US in 2018, where I did my residency and fellowship in Northern Virginia. Um, I'm really kind of a hybrid English American. I think football should be played with your feet, but I drink coffee, not tea. And I pronounce things like bath and trousers, but definitely burgers and fries over fish and chips. So I live in Virginia Beach. This is my family here on the left. We have my wife and my son. And actually, we have another one on the way. He's going to be coming in about a month and a half. So very excited about that. And in the top right-hand corner is my high school. This was Bedford School in England. And in front of this, you can see some of the students gathered around in a huddle playing rugby. And this is one of my big passions, rugby. And we're going to talk a little bit about it as we go through here, but it was kind of a big driver into me getting into sports medicine. And down in the corner is my little workout crew in the morning. I love CrossFit. This is what I do in my time off when I'm not, with the baby or at work or anything like that. And back on rugby, when I came to Virginia Beach here a couple of years ago, I got involved with 757 Rugby Academy. I'm now the vice president on the board there, and this is a youth rugby club in Hampton Roads. We have kids 7 to 18, and it's just really a fantastic sport, so I had to put that up on here. So what are we going to cover? We're going to go through non-operative orthopedics. And I'm going to define what this means. We're going to talk about the conditions that I treat in clinic, evidence-based practices, understanding kind of what non-operative medicine means, reviewing injection treatments and best practices for this. And we're even going to spend a little bit of time discussing some emerging therapies or things that are being utilized more and more these days. I use a lot of ultrasound in my clinic, so I'm just going to explain a little bit about what that is, how I use it, and the benefits that it adds. And the purpose of this talk really is about empowering you. I think we can, I really want to give you guys some good information that helps you make informed decisions about your own health. So that's the goal here. So what is non-operative orthopedics? Well, it's a comprehensive approach to musculoskeletal conditions. And really the priority is to treat people conservatively without surgery. We utilize a lot of different treatments, such as prescribed exercise, physical therapy, medical management, injection management, and things like orthobiologics, which I'll get into, and we'll talk about what those are. So why non-operative care? Well, many orthopedic conditions can be managed without surgery very effectively. It's first line, it's highly effective. There's less downtime. You're back doing the activities that you love and enjoy quickly. We reduce pain, improve function, and delay or even avoid surgery entirely. We focus on safe, effective, and individualized care. And the conditions we treat are really full spectrum of orthopedic conditions. This is starting with osteoarthritis. This is the wear and tear type of arthritis, not rheumatoid or psoriatic, but osteoarthritis, which is wear and tear. We see a lot of tendinopathy. Tendinopathy is an umbrella term for disease of tendons. So this is things like tendonitis or even tendon tears and ruptures and things like that. Bursitis it's an inflamed fluid-filled sac. So we see a lot of bursitis in the clinic. We see sports injuries and overuse syndromes, things like tennis elbow, golfer's elbow. We see injuries like ankle sprains or shoulder dislocations, head to toe sports injuries and overuse. I see nerve entrapment syndromes, things like carpal tunnel syndrome, tarsal tunnel syndrome in the foot, or, things like that. And I also see a little bit of back pain. This can be related to sporting injuries, stress fractures of the spine, and even some degenerative joint disease of the low back and spine-related issues like that. I have here a picture of the shoulder, and the shoulder is just a fascinating joint. I mean, we could talk for an hour just about the shoulder alone. It's got all of these issues in there. Osteoarthritis, you can have that in the shoulder joint itself, in the glenohumeral joint. You can have it in the joint above, the acromioclavicular joint. You have tendinopathies like rotator cuff tendons. You have long head of biceps tendonitis. And you can get bursitis in the shoulder as well, what we call subacromial impingement. You get dislocations in sports, and you can get nerve entrapment. There's actually a little nerve that runs through the shoulder called the suprascapular nerve, and this can often be pinched. The shoulder is a fascinating joint, deserves a lecture in and of itself, but we'll move on. So these are the conditions, and I'd like to spend the first part of this talk just kind of defining them, and explaining just a little bit about them in kind of basic terms. But osteoarthritis, this is the wear and tear arthritis. It's the most common joint disorder. About 1 in 5 adults will have this, 22% of adults, and 32.5 million Americans. It's also on the rise. I have the tire here with the worn tread. This is why I say it's kind of wearing out the tread. It's wear and tear of the joint. And on the left here at the bottom, there's a picture of arthritis at the base of the thumb. We call this the basal joint or the CMC joint, and it's actually the most common place in the body to get arthritis. So like I said, arthritis is increasing. And as our population on a whole, grows and ages, the prevalence of this is increasing pretty significantly. The projected increase is quite dramatic. And this is some, older data from 2015 from the CDC. But it holds true, and we do see this increase in osteoarthritis. It's a huge burden on society, time out from work, medical costs, and people avoiding activities that they enjoy, just through knee pain and things like that. So how do we diagnose arthritis? This is done through X-ray, and almost everyone who comes through the clinic gets an X-ray. It's such a valuable tool to start to diagnose a joint condition, a muscle or joint condition. And there are 5 cardinal features on X-ray that show us about osteoarthritis. You see the joint space narrowing here. I hope you guys can see my cursor on the screen. Myrna, can we see that? Good. Yeah. So, there's the joint space narrowing here. You compare that to the unaffected side where there's a good joint space, but you have joint space narrowing. You form these bone spurs on the outside of the joint called osteophytes. You also get chondral sclerosis, which is this bright white layer that we can see under here. Subchondral cysts, which are these dark areas. These are bone cysts. And cortical irregularities, which is the uneven surface of that arthritic joint. So these are kind of the 5 cardinal features of arthritis that we can see on X-ray. And usually that's sufficient to diagnose osteoarthritis. And this is a very important point about osteoarthritis. And I can't stress this enough. This is a total joint problem. It's not just wear and tear of the cartilage. It's actually a very, very complex total joint problem that, like I say, it affects the bone. You get these bone spur formations. You get the cysts underneath the bone, which can be painful in of themselves. In a healthy knee, you have the meniscus on either side. The lateral meniscus here and the medial meniscus, the inside meniscus, the outside meniscus. And in an arthritic knee, the meniscus is torn as well. So often people will have meniscus tears as part of their arthritis, but it's really part of arthritis. It's not a problem in of itself. It's part of the whole joint disease from osteoarthritis. So you can call this degenerative joint disease, to accurately describe it being a whole joint problem. And this slide is very complicated. There's a lot on it. And I'm showing it mainly to emphasize the complexity of osteoarthritis. It changes even the chemical composition of the fluid within the joint. So you can see the cartilage changes here. These are a lot of kind of inflammatory factors. But often what I'll tell patients is that, the whole joint is affected, and even the environment of the joint can be affected. And the chemical composition of that environment can change. So the way that we typically manage osteoarthritis is in a stepwise treatment algorithm. We start with very conservative things, low impact exercise. I like to say high intensity, low impact. We move up to topical pain relievers, analgesics, things like Voltaren gel, I think, is a very good tool for this. Oral non-steroidal anti-inflammatories. This is things like ibuprofen, Aleve, Motrin, naproxen. You can use orthoses, which is the medical term for bracing of the knee. You can use Tylenol, acetaminophen, glucosamine and chondroitin are supplements. And any sort of arthritis supplement that you get from the store will have these two ingredients in it, really, glucosamine and chondroitin. Turmeric is another supplement that's getting a lot of attention these days. And, if you fail the oral medications, the supplements and things like that, then we move up to injection therapies. This is with steroids or cortisone, corticosteroid injections, and gel injections. And we're going to describe all of these in detail later on in the presentation. But unfortunately, for arthritis, there is no cure. This is a degenerative condition that gets worse. And really, all we can do is slow its progress. And there are only really two ways to slow the progress, two evidence-based ways to slow the progress, which is weight loss and exercise. Everything else in this treatment algorithm is really just to manage the pain of osteoarthritis. And there are many ways to treat the pain. And ultimately, people do end up with a knee arthroplasty, a total knee replacement. This is a study right here in JAMA, which is a very kind of high impact, really good journal that talks about diet and exercise on knee joint load, inflammation, and clinical outcomes. And this was published a while ago. This was back in 2013, and it looked at about 400 or 500 obese older adults, and treated them with exercise and diet, and looked at the outcomes. And there was a dramatic improvement of knee pain, function, and outcomes, and delay of surgery. This has been since validated by many other studies. So tendinopathy, this is one of my favorite topics. And again, I'm going to keep saying this, but I could spend a whole hour talking about just tendons. I think they're absolutely fascinating. But tendinopathy, like I said earlier, this is the umbrella term for a diseased tendon. It includes tendinitis, tendon tears, scar tissue in tendon. And it's really just the umbrella term. And what this means is pathy means disease and tendon. So it's just saying tendon disease. That's what tendinopathy means, tendon disease. But it's a very common, really debilitating, painful condition of tendons. This can be immensely painful. You know, people who've suffered from tennis elbow and golfer's elbow will tell you it's a huge nuisance. And it's inflammation of the tendon, it's degradation, it's fraying, tearing. Um, and typically it affects people in their productive years. These are, you know, working adults, people in their 30s, 40s, 50s, you know. And it's also known to unfortunately be recurrent. It often comes back. And it's often associated with compensatory mechanisms, you know, people who have rotator cuff tendinopathy. It's associated with carpal tunnel syndrome through the compensatory mechanisms. It can result in arthropathy, which is, again, if you break this down, pathy is disease, arthro is joint disease. But, you know, rotator cuff tendinopathy and arthritis, because of rotator cuff tendinopathy, you know, they're heavily associated. You can get patellar tendonitis or tendinosis. And, you know, the effects of tendinopathy are huge. Over here on the right, you know, this is what a normal tendon looks like under ultrasound. This is the patella tendon. And underneath is a diseased tendon, a tendinopathic tendon. You can see the change in the architecture from this streaky white stuff that we see on ultrasound to this kind of, you know, dark gray area where you really lose that architecture. And this concept is very important to understand when it comes to talking about tendons. I'm going to talk about it in just a moment, but you know, tendinopathy is very prevalent. 30% of people who go to their PCP complain of tendinopathy. 50% of sporting injuries. And a lot of people remember this here with Aaron Rodgers rupturing his Achilles tendon. So, you know, tendons are, you know, they're fascinating. They're viscoelastic and neurovascular. They're not just this dead organ that is tensile only, you know, resistant to stretching forces. It's surrounded by a very rich blood supply on the outside of the tendon. And it's active, it's alive, you know. It's viscoelastic, which means it can withstand forces, both stretching forces, pulling apart, and compressive forces, you know, squishing together. And it has nerves and blood vessels with it, which is really why tendons are so painful. You know, this is a bit of a wordy slide here, and you know, it's getting into tendons a little bit, but I wanted to tell you guys a little bit about, you know, the change in the architecture, like I showed on that ultrasound image. You get these micro tears in the tendon, and they just heal poorly. You get these degenerative changes. You get deposition of different, you know, proteins and things like that. The tendon swells, it thickens, and you get this new blood growth into the tendon. All this new blood growth in there, trying to heal it up. And with blood comes nerves, and the nerves and the blood vessel and all this new kind of inflammation in there becomes very, very painful. And it's important to understand this kind of new blood growth bringing in the nerves. So that's about tendons. And I want to spend a moment talking about the bursa as well. So these are, you have bursa throughout your body. They often sit underneath muscles or between muscles and bone. And you can think of these as little cushions. Usually they have nothing in them. They're completely decompressed. There's no fluid in them. But sometimes when they get aggravated or inflamed, they can swell up. And when they swell up, they can cause problems. And at the hip, you actually have 4 different bursa, you know, at the outside of the hip here. But you have them, like I say, you have them throughout the body. And they come in, you know, the way that they cause disease is actually quite different depending on where they are. You can have true bursitis, which is, you know, just a primary bursal problem. This is when there's inflammation of that bursa itself. Because the bursa is inflamed, you have pain. And think of this is like at the elbow. You know, we call this olecranon bursitis. It's right at the tip of the elbow, and you get this big fluid-filled sac inflamed tissue at the elbow. And then there's pre-patella as well, which is, at the front of the knee. And these are common, like true bursitis. This is due to bursitis. But then you have a lot of secondary ones. A good example is the subacromial bursa, which there's a picture of down here at the shoulder. It sits underneath this bone called the acromion. And when people develop things like rotator cuff tears or rotator cuff insufficiency, just the mechanics can pinch that bursa and cause the bursitis or impingement. So it's less about the bursa itself. It's actually more about the rotator cuff causing the bursitis and the impingement. So I would say this is more of a secondary bursal problem, and you have to focus the treatment more on the rotator cuff rather than at the bursa. Same is true with, people call it hip bursitis. What we really know nowadays is that it's not the hip bursa that's a problem. It's more the gluteal tendons. Same with the ischial of the hamstring. And this is what I mean by that hip bursitis. Everyone used to call this hip bursitis and put steroids in there to calm down the inflammation in the bursa. But what we actually found, now that this is more, analogous to the shoulder. This is the same thing. When you have the gluteal muscle and tendon issues at the outside of the hip, this affects the mechanics, which then causes the bursitis. So by just treating the bursitis, you're not really getting to the root of the problem, which is this gluteal tendon fraying. The gluteus medius and minimus are implicated here. These are two of the muscles in the buttocks. But these muscles, it's the fraying of the tendon that causes that hip bursitis. So many people have been told that they have hip bursitis, but really this is a gluteal tendon problem, not a bursal problem. And like I say, it's analogous to the rotator cuff. And I see a ton of this. I see 4 or 5 of these every single day. So nerves is the next thing that I see a lot of. And I really like this illustration here. This encompasses a lot of what I do in this picture, because down here is an ultrasound picture of the carpal tunnel and the median nerve, which is the nerve that runs through the forearm right here, through the carpal tunnel, and supplies the hand. And I expect many people on this call have had carpal tunnel syndrome. It's very, very common, but it's pinching of that nerve. And I see a lot of this in clinic. On ultrasound, we can see this thickened, inflamed median nerve down here, right at the level of the carpal tunnel. And this is the median nerve, a little bit more proximal, closer to the body. At this level, the nerve isn't pinched, so you can see it's small and round here. But as it gets to the carpal tunnel, it gets flattened out like a pancake, and it gets very inflamed. And we can diagnose that with ultrasound in the clinic. Ultrasound is actually one of the best ways to diagnose carpal tunnel. So we see nerve entrapment syndromes like this. The carpal tunnel is an example, but you can have these, anywhere. You can have them in the neck with cervical radiculopathy, which is our kind of term for pinched nerve in the neck. You can have it in the shoulder, like I said earlier, the suprascapular nerve. In the elbow, we see things like cubital tunnel syndrome. In the wrist, I see carpal tunnel syndrome, which is by far and away the most common. If you have nerves pinched in the low back, we call that lumbar radiculopathy. It's a pinched nerve in the back. If it's pinched a little lower down when it forms the sciatic nerve, we call that sciatica, although often these two are used interchangeably. In the knee, we can see common peroneal nerve entrapment around the head of the fibula, which is the bone on the outside of the lower extremity. And at the ankle, I see things like tarsal tunnel. So these are common nerve entrapment sites, and we see them all over the body, diagnose them and treat them. So that's what I wanted to spend time talking about, just in terms of, the conditions. And now let's go on to some interventions. I might need to pick up the pace here a little bit. I'm looking at the time. And I do want to talk about these, but the treatment options, lifestyle and foundational care, this is where it all begins. This is activity modification, exercise, weight management, nutritional, and bone health. So this is interesting. The American College of Sports Medicine, this is our main governing body, now recommends that all healthy adults between 18 and 65 need to do moderate intensity aerobic physical activity for 30 minutes, 5 days a week. That means cardio. But they also added resistance training. So they also added weightlifting. And that was added back in 2011 with some really good literature on the effect of weightlifting on bone density and things like that. And here, exercise. I love exercise. It's the best thing that you can do for your body. It helps everything. Sleep, mood, blood pressure, energy, insulin sensitivity in diabetics. It boosts your immunity, reduces pain, especially inflammatory pains or things, even wear and tear pains like osteoarthritis. You know, the benefits of exercise are whole body. I've included 5 studies here, which are really like high impact studies, really from the 80s through the 2000s, which cement the importance of activity for overall health. And these are huge studies, really robust studies. One thing that I did want to mention, though, is our understanding about exercise and weight is actually changing quite a bit. Right here, I have someone swimming, someone biking, someone running. And if you do this for an hour, you can burn 430 calories swimming, 600 calories biking, 700 calories running. And, burning calories means that you'd think that means that there are fewer calories to go towards weight gain. But actually, there's a lot of literature now that supports that even if you burn 600 calories in an hour biking, your body actually compensates by burning 600 fewer calories. So over 24 hours, people roughly burn the same amount of calories, whether you exercise or not. Not to say that you shouldn't exercise. Like I say, it's one of the most important things that you can do for your health. But exercise and weight loss, we need to kind of separate those two. Exercise is great, but not so good for weight loss. And this is an interesting study here that looks at populations from all over the world and shows that essentially energy expenditure and is relatively similar despite different cultures, whether you're, sedentary or cultures that are even kind of hunter-gatherer cultures. So it's very fascinating. And this is what it's all about. It's all about healthy eating. Having a good portion of veggies, a healthy protein, whole grains, fruits on every plate, drinking plenty of water and avoiding sugary drinks. So let's move towards some specific conditions. And first, this is osteoporosis. This is the one I'm going to spend less time on as well, but it's a big problem. It's all about reduction of bone mineral density. It's very, very common. And, it's a spectrum. It goes from osteopenia, which is reduced bone mineral density, then, or it's like a precursor to osteoporosis. And this can predispose you to fractures like this, compression fractures of the spine, hip fractures, huge burden on the population. And the medical management for this mainly focuses around lifestyle and non-pharmacologic without medication. So we want good nutrition with calcium intake, vitamin D, exercise, which should be weight bearing, exercise and resistance training. This is really why they added the resistance training to their recommendations. Fall prevention, changing things at home, working on balance with Tai Chi, lifestyle. And here's a very wordy slide about some of the medicines that I'm not really going to talk about today. But resistance training, I think that this is very, very important. There was a landmark study in 1994, which looked at postmenopausal women, 50 to 70. And in one of the treatment groups, they had resistance training 2 times a week on 5 machines for 1 year. And they showed a dramatic increase in bone density in the spine, the hip, and the total body. Resistance training, weightlifting really helps. And this has been validated since by multiple other studies. Physical therapy is one of the big tools in our, in our treatment box. It's physical therapists are, it's a healthcare specialty that focuses on restoring movement, function, and quality of life in people affected by injuries. We have a really great team here at Jordan Young, but there are a lot of great physical therapists all over the area. They do a lot of different things, like they use modalities, hands-on care, manual therapy, blood flow restriction therapy, dry needling. These are all modalities that they can use to help get you better from your injury or from your pain. And they also teach people how to exercise, strengthen, and work on muscle imbalances, balance training, education on posture, which is hugely important. They educate on, body mechanics, injury prevention, and this can be used across all ages, full spectrum. Let's talk for a second about oral medications that we use as well. I love this quote. I've always liked this throughout my training. It's from Sir William Osler, who founded the residency program in the US. He's one of the founding fathers of medicine. But he said the person who takes medicine must recover twice, once from the disease and once from the medicine. I think it's so true. We need to use medicines judiciously in the right setting and be aware that everything is a risk-benefit trade-off. But the main medications we use are fairly safe. We use Tylenol, acetaminophen, which has many years of safety data. It's effective. But one thing that I often tell my patients is it requires regular dosing. What happens if you take a single dose of Tylenol is the level peaks in your bloodstream and then it tapers off. And that might not be enough to give you robust pain relief. But if you take 3 doses in succession, the plasma concentration or the level of the drug in your bloodstream meets a more constant level, which will give you some good pain relief. So I often recommend taking arthritis Tylenol, which is the extended release 8-hour Tylenol over just regular strength Tylenol. But you have to make sure that you stay less than 4,000 milligrams in 24 hours. So that would be 8 extra strength tablets or 6 arthritis strength tablets in 24 hours. And you should space them out. And then non-steroidal anti-inflammatories. This is your Advil, Aleve, Motrin, naproxen, all of these ones. These are effective too, but they come with risks. Risk of bleeding. They can affect your kidney function. You can't take them if you're on anticoagulation. And you've got to be cautious with these. You don't want to take them every day. And then we move on to injection therapies. Now, I need to emphasize that these are tools. Injections are tools. They are not cures. They don't cure the problem in of itself, but they are great tools that we can utilize to help improve your pain. And they come in 3 main categories. Corticosteroid, which is a cortisone shot, steroid shot, gel shots, and orthobiologics. So the cortisone shot, this is kind of the bread and butter of orthopedic medicine. We've been using this for many, many decades, and it treats your pain. That's what it does. You put cortisone in a joint, it calms down inflammation, it dramatically improves your pain. But it comes with some trade-offs. Like I say, everything's risk-benefit analysis. And it provides short-term relief only. We have, data here from JAMA, again, high-impact journal, really good journal. In 2017, the effect of an intra-articular steroid shot, triamcinolone, this is the cortisone that we use, versus saline on the knee cartilage. They looked at, patients and put them into steroid injections every 3 months for 2 years versus saline injections. And they found that really your cartilage is thinned, and the knee pain is worse over time with steroid injections. So they are toxic to the cartilage. Great in the right setting, in the right patient at the right time, do a steroid shot. It's great. It'll improve your pain significantly, but be cautious with repeated steroid injections. And around tendons, we really back up that data. Short-term relief covers up your pain for 60 to 90 days, but it can worsen intermediate and long-term outcomes. We have robust data from lateral epicondylalgia, which is tennis elbow, where we know that 1 year out after a steroid injection, people are doing worse off than if they had a saline injection. That being said, again, steroid injections are great for pain relief. They can really improve your pain in the right setting, but you have to have a risk-benefit, shared decision-making about the risks and benefits of the steroid shot. And if you do them before a knee replacement surgery, we know that it increases your risk of post-operative knee infection. So after a steroid shot, you have to wait 3 months before you can get surgery. And we also know that if you get a steroid shot, it will increase your blood sugars in people who are diabetic, for 24 to 48 hours. So the advantages: fast relief, cost effective, anti-inflammatory, great for short-term pain relief. We use it for arthritis flares, bursitis, tendonitis, but it's short-term. It can accelerate arthritis, and it can increase the risk of rupture in tendons and fascia. So here's gel injections. And I've included this chicken here because this used to be taken from the rooster comb. It's hyaluronic acid. This is a protein that is found in the human body and animals and everywhere. It's ubiquitous. And what it is you inject this thick gel into the knee, primarily in knee arthritis. That's the only area it's actually approved for. And it can improve pain and function. And it's best in mild to moderate arthritis. Lots of different preparations. Lots of different. We can have, there are all these different brands. Suparts, Orthovisc, Euflexa, Synvisc 1, Durolane. And I utilize a lot of these. I use most of these different injections. And the main difference is the thickness, the molecular weight, how viscous the solution is, and whether it's a kind of a one and done shot, like Gel 1 or Durolane or, Monovisc, or if it's a 3-shot series like, Euflexa or other things like that. By the way, they're all pretty similarly effective. And when I say similarly effective, maybe I should say similarly ineffective. They provide modest relief, not as robust as steroids, but it may last a little bit longer. And really, this is the data since 1983. We've been doing these up until 2021. And what we show is a consistent small benefit from gels that typically lasts about 6 months or so. So they're good. They're good in patients who have failed steroid injections for knee arthritis, but are not yet ready for anything surgical. And I do utilize a lot of gel injections. So the pros: they're covered by insurance if you fail steroid injections. They can last longer, about 6 months compared to about 3 months with steroids. And we've been doing them for many years. They're safe. But, they're not quite as effective as steroids. And they're expensive without insurance, very expensive. Insurance companies, the coverage does vary on these. And finally, the injection therapy, the third injection therapy is orthobiologics. And these are relatively newer. These are biologic agents from your own body used to treat orthopedic conditions. But we do have to be very careful about how we use them. The FDA changed their wording on how they want these orthobiologics used, and they include very specific wording about minimally manipulated. So when we take these products from your body, we cannot manipulate them very much. And they have to be used for the same basic function from you where we took it and putting it back into the body. But let's talk about them a little bit. Platelet-rich plasma. This is the one that we use the most. PRP. And some of my patients on the call may have heard me talk about this before. But what it is, it's a blood product. We take your blood, we spin it down, we concentrate it, about 3 to 5 times the baseline concentration of platelets in your blood. Platelets are kind of healing cells. They're involved in the healing cascade. It contains all these kind of growth factors and inflammatory factors and mediators of healing in that concentrate. And then we inject it into a joint, a tendon, a ligament, or anything like that. There are different variants. We can have leukocyte poor or leukocyte rich. These are different ways to prepare PRP, used for different purposes, and spun different ways. But we use them mostly in osteoarthritis, knee osteoarthritis, or in chronic tendinopathies, things like tennis elbow, Achilles tendonitis, patella tendonitis, plantar fasciitis, and gluteal tendinopathy, what we used to call hip bursitis. We do these in 1 or 2 shot injections, and it's a great treatment for pain relief. This is how it's done. In the clinic, we take your blood, we put it into the centrifuge, we get these layers of plasma and platelets, and then we inject that back into the target tissue. This is kind of my handout that I give to patients to, explain what to do before the injection, the day of procedure, what to expect during the procedure and following the injection. PRP is a great treatment. The main downside of PRP is that unfortunately it's not covered by insurance. It's all out of pocket. We have some great studies, for its use. And really, knee osteoarthritis. This is back in 2013, a double-blind randomized controlled trial showed that it was beneficial compared to saline, but it's being proven beneficial compared to steroids as well. This is a more recent one in 2018 at the greater trochanter for those lateral hip tendons that we were talking about, lateral epicondylitis, plantar fasciitis, and really we're getting more and more evidence all the time. The intention with PRP in these structures is to improve pain. It doesn't really help heal up these structures too much. It can a little bit in tendons, but in joints, it doesn't reverse or change osteoarthritis. What it does is it helps treat your pain by really treating that inflammatory environment that we were talking about earlier. Bone marrow aspirate concentrate. This is what people would call stem cell therapy. This is when we take concentrate from the back of the pelvis, usually. This is when we take bone marrow in an invasive way, and inject this into the target tissue, the joint, the tendon, things like that. And this has a lot of kind of regulatory or modulatory effects, ways to kind of improve that environment of the joint or help heal a tendon. Really, we do not have robust data for its use now. A lot of its use is experimental. It's emerging. It's gaining benefit. But really, the studies have been variable. They haven't consistently shown benefit. But in the right patient, bone marrow aspirate and microfragmented adipose tissue, which is another way to harvest stem cells, this can be considered. MFAT, microfragmented cell adipose tissue, is when we take fat from the belly and we kind of break it up a little bit and inject it into the target tissue. And the advantage of this is both of these, the bone marrow and the fat, both contain stem cells, which can help healing. But the fat is contained in this architecture. And the architecture allows it to adhere to different tissues and kind of improve the healing process there. Really our evidence is limited to case series, small case series, and the evidence is very limited. There are niche examples of when you might want to use this, for certain rotator cuff tears or ligament or tendon tears and people who cannot get surgery to fix those. But there's a lot of exciting things going on in the world of stem cells of microfragmented adipose fat tissue that we can use. So a quick recap on the injections. Steroids, cheap, readily available, accessible, covered by insurance, but may accelerate arthritis. Gel is longer lasting, it's safe, requires prior authorization, and it can be less effective. And then you have your orthobiologics, which are also safe. They're your own body's product. They can help heal, but they're expensive and not covered by insurance at all. They can also be very, very painful. And finally, I know we're running a little bit low on time, but I do want to quickly talk about ultrasound, which is what I heavily utilize in the clinic. This is the machine I use. It's the Logic-E. It's a great machine to look at tendons and ligaments and joints. And right here is the perfect example of its use. This here is the bone of the shoulder. And right above it, we have the rotator cuff. And you can see this hole right here with some associated bony changes underneath it. This is a rotator cuff tear. You don't need an MRI. You don't need anything other than the ultrasound, which can just be put on the shoulder right in the office, and it can show a rotator cuff tear right there. And then it can also guide my needle to put it between the rotator cuff, which is right here, and the bursal layer, right into that bursal layer with absolute precision. So here's bone, here's tendon, and here's a needle coming right into that bursal layer. What, ultrasound can and can't do certain things. What can it do? It can look at muscle. It can see this striated. It looks like steak. You can see all of this right here. It can look at bone, but it can't see through bone. It reflects right off the surface of bone, and it's just black underneath. You can't see anything under bone. But you can see through fluid pockets. And fluid pockets look like these big, what we call anechoic, the black areas of fluid that you can just see right through. You can see nerves and tendons. You can even see ligaments on ultrasound too. So you can see torn ligaments like the UCL. How I use it in the clinic, I look at the shoulder. Is there a torn rotator cuff? I look at the elbow. Is there severe lateral epicondylitis? Tennis elbow. How bad those tendons look? In athletes and my baseball players, I look at the UCL. Is it torn? Is it competent? Is this something that we need to think about, being aggressive with at the UCL? Like I mentioned earlier, you can diagnose carpal tunnel. You can look at that median nerve. And in the hip, we can look at bursitis versus tendonitis and tendon tears, although the hip is actually quite challenging to view because it's quite a deep structure. And the problem with ultrasound is it just doesn't penetrate tissues very well. But in the knee, you can see joint effusions, extra joint fluid, and you can see Baker's cysts. Where you can look at the Achilles and diagnose tendon tears, ruptures, or even just tendinopathy, thickening of a tendon. And then in the clinic, I use it a lot to guide my injections. In fact, I do every single injection under ultrasound. And that's for multiple reasons. I have some trials here that talk about the accuracy. So, ultrasound improves the accuracy, especially in the hip, the knee, the shoulder. Ultrasound is just highly accurate at guiding the needle. It also shows that people with carpal tunnel injections, here's a meta-analysis, which is a big, robust type of trial. It shows that people have better symptoms and function scores with ultrasound versus landmark guided. And knee injections, it hurts less. And I think a lot of my patients can, say that knee injections really don't hurt that much with these lateral knee injections under ultrasound guidance. But in fairness, sometimes it's not necessarily indicated. There are studies that show if you inject the shoulder, the subacromial bursa, it's no better doing it under ultrasound or under landmark. You have the same effect. I still do it under ultrasound just because, I like to be precise. I like to see it. And I think, patients appreciate the accuracy. And there is some variable data here. So practically, I use this to guide deep or small joints, the hip, the glenohumeral, AC joints. I guide it to the bicep sheath at the front of the shoulder and the carpal tunnel. I use it when precision matters. So if I'm doing a visco, like a gel injection, or if I'm doing PRP or after a failed prior injection. And I do it to reduce procedural pain. I'm going to skip over these slides. I'd love to talk about it, but we're running low on time. And just to summarize, we went through the background, we went through my background, we went through, what my goal is of this talk, which is empower you guys with knowledge. We talked about joints, tendons, bursa, muscles, and nerves. And we talked about exercise, PT, medications, injections, steroids, gels, orthobiologics, and we talked about ultrasound. So really, what I do is an individualized approach. It's the right treatment for the right patient, and it's multimodal care with physical therapists. And sometimes surgery is indicated, and I can guide people towards that. And sometimes if they come in and, I just don't think non-operative care is the way forward for them, then I tell them in an unbiased way that surgery is what they need. And we have a really, really great team of surgeons here as well. So, you can expect shared decision making. We can discuss realistic expectations of what we can achieve with the non-operative treatments, the timeline, how long this is going to take, how long the shots are going to last. And we also talk about insurance and cost, unfortunately. These are part of healthcare these days. And with that, I did have a case example to go through. I'm happy to go through that at another time if we need to, but I'd like to open it up to questions. And Myrna, am I at a good point to do that now? Good, I'm getting nods. So let's see. I've got a few questions in the chat. I'm going to read through these here. I'm going to move the, let's see if I can try to move this over a little bit. Okay. Let's look at the chat here. I'm scrolling up to the top. Okay, we have some, yes, we can watch a recording later. Give blood, play rugby. I love that one. That's great. Good. Yep, you answered that one already. I'm not sure. Can we do questions out loud? Can people ask them verbally, or is it through the chat, Myrna?
It's chat only.
Chat only.
Yeah, so your first question is by Willis at 6:41. I've been told by 2 surgeons I have lumbar fusion surgery. That first one.
This is a difficult one. And this is a big question. And it's actually a little bit outside of my field. The back in of itself is its whole specialty. This is really managed by physical medicine doctors. We have a great team with Dr. Levy, Dr. Horn, Dr. Amjad. And they could better off, answer this question for you. Unfortunately, it's just a little bit outside of my wheelhouse. So I'm going to move past that one.
Oh, let me interject. We do have 2 doctors presenting later on back and lumbar. So please check up our website to see when those lectures are going to be.
There we go. I'm going to move past some of the back questions. Back is a huge, huge issue. And I think we'll be addressing that at a later seminar. 40% meniscus removed, right knee, and tear in the middle of the meniscus in the left knee. Cortisones every 3 months, both knees. I've lost. Good. Yeah, so this is a very common situation here with meniscal. Once you remove some of that meniscus, you are going to develop arthritis in that joint. You're doing all the right things here. You've lost 67 pounds. That's excellent, and that's extremely hard to do. So congratulations to you. You're using topical gels, Voltaren gel, which is good between shots, and you're doing steroids every 3 months. I'd really have to look at the knee x-rays to see the severity of the knee arthritis. but I think you could try gel injections. You could try visco supplementation. And if the arthritis is mild to moderate on the x-rays, certainly you could try the orthobiologics with PRP as well. Other things are oral management. And I think, Tylenol is really underutilized. Um, Tylenol is, just the regular dosing, add on the anti-inflammatory as well, and look at some of those supplements, turmeric, glucosamine, chondroitin, maybe even try the anti-inflammatory diet to kind of work on those weight loss, to help augment those weight loss gains as well. What should I do? This is a continuation of that. What should I do? Get the surgery or what? I really don't want the 70% success rate of surgery. I think this really depends on, like I was saying, how bad those knee x-rays look. Really, in end-stage knee arthritis, when you failed steroid injections, surgery is the definitive treatment. Knee replacement surgery. What we can do with non-operative treatments, is, pretty significantly improve people's pain. But there's a time and a place for knee replacement surgery as well. But I'd be happy to see you in the office and look at those x-rays and see if there's anything else that we can add in addition. I have another back question, and I apologize. I'd love to target these, but we're going to leave them for the back team, okay? Okay, here's a good question. So, good evening. This says, thank you so much for your work and commitment. I did PRP at the facility where I had it done, added ozone therapy to the enriched plasma. What are your medical thoughts on this? So what are my medical thoughts on adding ozone to PRP? This is not part of my practice. Ozone is a really interesting therapy. It's air. It's ozone. It's natural air. It's sterile, but it's air injected into the joint. And there is some interesting data on this, but it's very small case series. And when it's combined with PRP, the medical evidence for it is currently limited. This would be experimental use at this stage. I don't utilize it, but there is some evidence for this. I don't think it's unreasonable to add ozone. Also, what people are doing is trying to supercharge PRP sometimes. And what this means is having people exercise before PRP, which leads to a lot of platelets being dumped into the bloodstream. So you get a higher concentration of platelets. These are kind of very novel ways to try and augment PRP further. And the evidence is very small at this time, but these might be, more utilized in the future. So do collagen supplements help health of tendons? And secondly, why do insurances not cover PRP? Great questions. Do collagen supplements help the health of tendons? Honestly, no. If we look at the meta-analysis of collagen supplements, which meta-analysis is a way of, looking at tons of data. But if we look at tons of data and lots of different trials, it really doesn't pan out. It doesn't help the health of tendons. That being said, I do have patients on collagen supplements, and I have patients on glucosamine and collagen and glucosamine and chondroitin, and they say it's highly effective and it helps their pain a lot. So I think you have to separate sometimes the data and what people experience. Do I think it does harm? No. So I think it's absolutely something that you could add to your treatment, but really the data does not show that it definitively helps tendons. And why do insurances not cover PRP? Yeah, this is kind of a difficult question. It's partly about the history of PRP. When PRP initially came out, there were some good studies that showed some very beneficial, very beneficial early results, and a lot of people started utilizing PRP. in ways that we had no evidence for. Then some trials came out that said it didn't help in some specific areas. And there was kind of a knee-jerk reaction to take it off the insurance coverage. TRICARE was covering it up until recently. And I expect in the future, with our growing evidence for PRP, it likely will be covered, but it will be for certain conditions where the evidence is robust. And really, we still need to work on growing this evidence base. Another question, if I already have a doctor at Jordan Young, how can I have an appointment? You can see multiple of us, multiple physicians at Jordan Young. We actually all work very, very closely together. We share a lot of patients together. And it's really, a multidisciplinary team where, if we'd be happy to see all of each other's patients, we're always happy to do that, and work together to help you get better, surgically or non-surgically. So PRP, from extraction of blood to injections, what is the turnaround time? Anywhere between 30 minutes and an hour. Is Tylenol okay for long-term use? Yes. You don't need to monitor liver or kidney function, but you do need to take less than 4,000 milligrams in 24 hours, and you should not take it with alcohol. How do you diagnose tendinopathy? Great question. Clinically, which means with examination, as well as on ultrasound, as well as with sometimes other advanced imaging, MRIs, things like that. But mostly it's clinically. It's in the office visit through physical exam and history. This is a good question. Of all the tools you covered, what would you suggest for knee bone spurs? Now we actually call these essential osteophytes. We call them essential because if you take away knee bone spurs, your knee pain gets a lot worse. What knee bone spurs do is they distribute forces throughout the knee and they decrease knee pain. So we do not treat bone spurs at the knee. Leave them alone. They are not what is causing your pain. What is causing your pain is the arthritis. And the knee and the bone spurs in the knee are actually essential. They're needed. They help distribute forces and decrease pain. So, how about PRP and umbilical cord stem cell on ankle joint? So PRP on the ankle joint, absolutely. It's a joint. I think PRP is helpful to improve the environment of the joint. But umbilical cord stem cell is a no-no in the US because it's not autologous use. It's not from yourself. You cannot take stem cells from someone else or process them in any way and inject them into a joint. So I would say umbilical cord stem cell on the ankle joint, no. But PRP, sure, in the right setting. Another question, you never mentioned cervical spine treatments with PRP and stem cells. I like this question. There's some great data on this actually that has come out from Jordan Young. Dr. Levy and Dr. Horn did a trial on PRP and stem cells inside discs. And they would be happy to talk to you about that data. Can ultrasound on both elbows give a definitive diagnosis? Yes and no. It can diagnose some things, but not everything. There are certainly limitations to ultrasound. It can show swollen and inflamed nerves, and it can show tendon problems, but it can't diagnose every problem in the elbow. That is more clinical. That's the, physical exam, the whole evaluation. Oh, we have a lot of questions here. Myrna, you just give me a nod. I'm going to keep working my way through these. I see there are 18 new messages on here, and I'm trying to work through them. But I'm going to skip over the back ones. What is considered a fail on steroid injection? I get this question a lot. I would say less than 2 months of pain relief would be a fail on a steroid injection. How expensive is PRP? It varies from clinic to clinic. We can discuss that if you like separately. does a torn meniscus have impact on the success or longevity of gel injections? Um, you know, it does in the fact that indirectly, if you have a torn meniscus and bad arthritis, then gels are less effective. If you have a torn meniscus and mild arthritis, then gels can be more effective. So not in of itself, but as part of the overall disease of the knee, yes, the pathology of the knee does have has an impact on the success and longevity of gel injections. Is there a way to treat a ruptured tendon other than surgery? It depends on the tendon. Achilles tendon, for example, when it ruptures within the tendon sheath, and this can be effectively managed non-operatively. Rotator cuff tendons, unfortunately, just don't, if it's ruptured, if it's fully retracted, these don't do well non-operatively. If I see someone with a full thickness retracted rotator cuff tendon tear, I have an honest discussion with them and I say, hey, look, this is likely one that you can get some benefit from surgery. And this is when, you really have to be with a multimodal team to, make sure that you're getting the right treatment here. Can osteoarthritis affect the whole skeletal system? Yes, it can. If you have it in one place, you likely have it in other places. There are three main contributors to arthritis: genetics, obesity, and injury. And genetics, I often see people who have this in many, many joints throughout their body. Some questions here: turmeric for inflammation versus curcumin. I think fairly similar. CBD treatment. I think there's some interesting research on CBD ointments. It's all very small patient studies. I don't know of any large randomized controlled trials or anything like that on CBD. I know it's not well, regulated. It's more of a supplement rather than a medication. But I have a lot of patients who utilize CBD and have some good benefit from it. Resistance training. What type of resistance training do I recommend? Whatever you can do. I think, everyone can do resistance training. And that might mean, lifting 3 to 5 pound dumbbells, or it might mean doing heavy back squats or clean and jerks in the gym. Resistance training should be whatever you are able to do comfortably without risking injuring yourself. The principle of resistance training is to, be lifting weights or cables or pulling or basically creating micro trauma to the muscles that helps muscle growth and also providing that stress on the bones to help bone deposition. An MRI is absolutely not necessary prior to an appointment with me. Often an MRI is actually not needed. And sometimes patients have come in with an MRI already ordered and we've canceled it because it doesn't change the treatment algorithm. So there's a time and a place for an MRI. It's not always used just to diagnose. It's often more used actually for procedural planning. What gel injections does Jordan Young Institute use? And why are they chosen? We use almost all of them. I use Euflexa, Durolane, Symvisc 1, Monovisc, Hymovis, Gel 1. And the decision that goes into choosing them, I tend to go for the one injection series just because it's a lot more convenient for the patient. But often actually insurance dictates which one we are allowed to use and they have preference. So when we go through the prior authorization, insurance sometimes specifies which gel they want us to use. We have all of them. And, patients can also choose if their insurance allows it. I had my knee replaced at Jordan Young 2 years ago. Above my knee, it hurts when I walk up and down stairs and get out of a chair. Can you look at it and see if there's an issue with the muscle? Yes, ultrasound can definitely show this. We can see if there's an issue with the muscle. Um, sometimes after knee replacement, there is pain afterwards. And, sometimes it's hard to find the cause, but it's definitely something that we can look at and see if there's an identifiable cause there. Okay, this is a great question. If non-surgical treatment is selected first, will the condition worsen if surgery is delayed while receiving non-surgical treatment? Absolutely. There are definitely cases where you have a window phase, and early treatment with surgery can prevent long-term complications. I do not treat people non-operatively for the sake of non-operative treatment. I treat people non-operatively often because it's first line and we can make meaningful improvement. But if there is a time when condition will worsen without surgery, I tell people up front and I say, hey, let me get you in with one of my surgical colleagues. We'll get you in, we'll have that discussion, and I think this is likely going to need surgery. A great example of this would be an acute full thickness rotator cuff tear. If I diagnose in the office an acute full thickness rotator cuff tear, I go right upstairs to one of my surgical colleagues and I say, hey, look, I think this guy needs surgery. We look through the MRI or the imaging or whatever we have. We go through the case and we can get that patient, the treatment that they need. If you delay surgical treatment on acute full thickness rotator cuff tears, you can cause rotator cuff arthropathy and the treatment and long-term problems. The same is true for like a distal biceps rupture. If you rupture your distal biceps, if you pop that tendon, you need surgery within a month. Without surgery, or if you wait longer than a month, the surgery becomes technically very difficult and outcomes are worsened. So absolutely, if non-surgical treatment is selected first, conditions can worsen. With me, if when I see you, I make that, I tell you that, and we get you the care that you need. Are you numb when injecting the gel? You actually don't need a numbing. Um, the injection is actually fairly tolerable. I go in the suprapatellar recess, which is above the kneecap in the outside part of the leg. And the way that I do the injection under ultrasound guidance with gel, it's actually very tolerable. It doesn't hurt very much. You don't need numbing at all. People do very well with it. They're often quite surprised that it hurt a lot less than they expected. You did not mention osteonecrosis. Is that just medications until surgery? I did not mention osteonecrosis, and I do see a lot of osteonecrosis. There are a lot of conditions that unfortunately I just can't go into in this hour presentation. Non-operative medicine is really my entire field. There are lots of conditions that I'd love to talk more about. We'll maybe have to save that for another lecture.